Hello, everyone. Welcome to this special webinar, Getting to the Finish Line with CMS-0057. My name is Daniel Vreeman, and I'm going to be your host for this discussion today. And you all are in for a real treat because we have a great collection of participants today, and our panelists are top-notch. We're going to be talking about real-world implementation of HL7 FHIR for prior authorization. And today on the panel, we have my colleagues, Viet, Diego, and Allison, and I'll have them each say a little bit of introduction. But first, for me, I am Dan Vreeman. I serve as the Chief Standards Development Officer and Chief AI Officer for HL7 International. Viet, how about you?
Hi, I'm Viet Nguyen. I'm the Chief Standards Implementation Officer, and I oversee the FHIR Accelerator program and also serve as the Technical Director for the HL7 Vinci Project. Diego?
I'm the Deputy Chief Standards Implementation Officer for HL7 International.
Perfect. And hi, everyone. Good afternoon. My name is Allison Slayton. I'm a strategic solution architect with Cognizant, focused on all things interoperability and FHIR, connecting payers and providers. So excited to be here with you guys today. Thank you.
Terrific. Well, and we're glad that all of you have joined as well. We would love to know a little bit about you and what brought you to this event. And so if you don't mind, feel free to share in the chat your background and what you're interested in or hoping to learn out of this session. We hope to be able to respond and interact with the comments and questions that you put in the chat as we go. But to get started, let me give you a little bit of an overview of what HL7 is all about. So if we can have the first slides up there. HL7 itself is a nonprofit standards development organization. And let's see here. Get that going. There we go. Founded in 1987, you may know us from some of our other standards, the venerable HL7 version 2 standard or our CDA XML-based document standard. But what we're here to speak about today is our modern interoperability framework, HL7 FHIR. HL7 itself is really dedicated to enabling improved health around the world through open standards that facilitate interoperability of systems. But the way that we approach this work is recognizing that the development of standards and their use and implementation throughout the marketplace is really a virtuous cycle. And this graphic sort of illustrates a little bit about how we think about that interplay between standards development and standards implementation, because standards are ultimately designed for and meant to serve people. And so the whole process starts with a community of practice, a group of stakeholders who get together and believe that there is a challenge that they're facing with interoperability that they can't solve by themselves. And through a review of what's sort of out there in terms of technical specifications, ultimately, a lot of times folks decide that they want to create something more specific to their use case. And that sort of kicks off a process of standards development where we try to fine tune the technical requirements to meet those demands for that information exchange. And built into the process of our standards development process at HL7, even before we get to publishing something, really is sort of this iterative feedback through implementer testing at events like Connectathons, the development of reference implementation software released under an open source license. So those who are experimenting with these early versions of the specification, as well as the ones once they're published, have something to interact with. But then even after we sort of go through our formal balloting and comment resolution process and publish a version of the standard, we know that the journey is really just beginning. And so ultimately getting adoption and use in the marketplace takes a whole community, and that's part of what we're here to do today. So HL7 really cultivates a community around the world of different participants, both here in the United States and in our affiliate countries, more than 40 of them. We connect with regional partners to build capability in informatics through education and through training and hands-on events. But a real key driver of the application of FHIR to particular domain areas comes from our FHIR Accelerator program. So each of the FHIR Accelerator programs has a particular collection of stakeholders who have gotten together to focus on using FHIR for a particular area that they care about. The Argonaut project is focused on some of the fundamental capabilities of FHIR, including specifications like US Core, things like bulk FHIR and Smart App Launch. We have the FAST task force, which is really focused on sort of the infrastructure and scalability aspects of using FHIR at, say, a nationwide scale. The Gravity project is focused on using FHIR in the context of social determinants of health. The Karen Alliance has developed a number of guides that are focused on different use cases for consumer-directed exchange. Codex has taken up a variety of projects related to the use of FHIR in the context of clinical research. Helios has focused on using FHIR in the context of public health data exchange between the clinical care system and the public health system. Vulcan has really picked up that that clinical research side as well. And from Codex perspective, I must have misspoke. They're focused on first domain areas such as data sharing and oncology, and have picked up other domain areas such as cardiology and genomics as well. But what we're going to spend a lot of time talking about today is really the work of the Vinci Project, the FHIR Accelerator focused on the exchange of data between payers and providers. And one of the key areas that they've done a tremendous amount of work on is the use case of prior authorization. But just to give you a sense of what's kind of happening in the HL7 ecosystem around the use of FHIR, what we're going to be talking about today is one part of that broader puzzle. And so across the landscape, different groups are working on the use of FHIR for things like oncology data element sharing, consumer-directed payer data exchange, the use of FHIR to share data about radiation treatment, for creating national healthcare directories, for doing things like continuous glucose monitoring, and even aspects of clinical information representation that you might not associate with FHIR, such as representing knowledge artifacts like evidence-based medicine resources in the same technology and infrastructure stack as the core clinical data is represented. So really, there's a wide range of applications for FHIR. And across these different projects, there's really sort of a combination of standards-based capabilities that are brought to bear. So these, what you see on the slide here are sort of the parts of the toolkit from HL7 that can really serve as rocket fuel for all kinds of digital health innovation. These are standards like FHIR that represent a way to get semantically interoperable health data at scale, combined with the HL7 Smart App Launch specification, which handles the ability to authorize and authenticate third-party applications to systems that have FHIR data, such as electronic health record. The FHIR bulk app specification, which is a technique for getting a large dump of FHIR data, which can be super useful for things like training AI models. A new capability, Smart Health cards and links, which allows you to share verified health data via something as simple as a QR code or a link. We have techniques like are defined in the CDS hook specification, which is a way to integrate third-party decision support solutions right in the workflow context of a health IT system like an electronic health record that a clinician is using. We have the clinical quality language specification, which is a way to represent clinical knowledge and metrics in a standardized format. And last but not least is the HL7 standard for structured data capture, which is a way to represent different kinds of forms or questionnaires with really advanced data capabilities like pre-population that can really drive efficiency in a whole bunch of different use cases. So that's a bit of our introduction of why we're here, what HL7 is all about. And now to sort of dig deep into the prior authorization use case, let me turn it over to Viet, who's going to give us an overview. Viet, the floor is yours.
Thanks, Dan. I'm glad you covered those different technologies because they really are building blocks to our ability to do a number of use cases, including the ones that we're going to talk about during this session. So I have a handful of slides I just wanted to show you all to kind of level set on what we're doing and have done in the burden reduction domain. So on the, I guess I need to take over. So this slide represents a number of the implementation guides that were created by the Da Vinci Project to address exchange of interoperable data between payers and providers. And as you can see on the top right here, these three are the core of the guides that we use in burden reduction, but there are also roles for other guides, including our clinical data exchange, our payer data exchange, attribution, and the use of CQL to represent the data that payers will be asking for when it comes to prior auth. So just to level set a little bit, this is a high-level diagram of the 3 or 4 major guides that we use when it comes to prior auth. And when I like to talk to clinicians about this, and they ask me, well, what does it help for us to do? I tell them 3 things. One is that it closes an information gap. Number 2 is it gathers, using FHIR technologies, gathers information for the clinician so that they don't have to hunt and peck for information. And number 3 is status. So we have the coverage requirements discovery, and we'll talk about each of these in just a moment. We have documentation, templates, and rules. We have the prior authorization support and the clinical data exchange when we need it to get additional data. So we have, we use some additional technologies. Dan mentioned CDS hooks in order to bring this prior authorization information at the time the provider is with the patient at the point of care so they can do shared decision making. We also use the FHIR APIs and other technologies within FHIR like questionnaire and the clinical quality language in order to gather data. And then we can bundle it all up and send it to the payer as a FHIR bundle because we were, the whole community was given some enforcement discretion to not have to use the X12-278, but they can use that format in order to exchange with the providers. So I'll go in a little bit into each of these guides. So coverage requirements discovery. Imagine being a clinician with the patient and you need to order a study, let's say a head CT. Well, often as a clinician myself, we don't know whether or not we need a prior auth. We may or may not know what coverage the patient in front of us has, and we certainly won't know whether or not it's a covered service or requires a prior auth. Well, in this step, the provider puts in an order for a head CT, and in the background, the EHR or other systems knows the patient's coverage, goes out to the payer for that patient, and provides the information of the coverage information as well as the order, and asks the payer, does this require prior authorization? And using other technologies to gather data if necessary, they send a response and say either there's no PA requirement or there's needs more information. And so that's really helpful to the provider because we'll know at the time, as opposed to me putting in an order and then the back office having to check using a portal, which we want to try to eliminate. And it prevents us from delaying the initiation of a procedure or a study that we want to have for the patient. So that covers the first, do I need a prior authorization? If it turns out we do need a prior authorization, a second question comes up, which is, well, what information does the payer need me to submit in order to get this covered? And again, there's an information gap because I don't know what forms or data they need. And often in today's world, we ask the back office staff to go to a portal, find a form, give it to us at the end of the day that we fill out and then has to be submitted. What we want to do here is to bring those data requirements to the provider at the point of care, use FHIR and FHIR resources to gather that data for them, as opposed to having them hunting and pecking in the EHR. And then everything that is structured is automatically kind of fills out the data requirements. And then when there may be a narrative necessary, hopefully it's short, the provider can fill that out. And that really helps, again, with the shared decision-making with the patient. And once this data is all gathered or completed, we then want to submit it through the prior authorization support. So we bundle up the data either as a FHIR bundle, a collection of data, or we do a translation to X12, send it over to the payer, and the goal will be the payer has all the structured data and then can send back an adjudication in real time that the prior authorization is either approved, not approved, or additional information is needed. And when that is needed, we can still use FHIR to gather that additional data so that we decrease that burden on the clinician. So these 3 guides that I just mentioned were included in the CMS Interoperability and Prior Authorization Final Rule, we call CMS-0057. And this rule really primarily covers payers who provide federally funded care, like Medicare Advantage and Medicaid and CHIPS. But the goal is to get these prior authorization decisions done more quickly, within 72 hours for urgent prior auths and within 7 days for non-urgent. And that's really important because I've heard many stories of patients getting surgeries delayed or other studies delayed because the delay in getting the prior authorization. The CMS describes a number of APIs, the patient access API, provider access API, a payer-to-payer, and the prior authorization. These are, I like to say, CMS's terms for these APIs, and we have a table that shows which of the implementation guides support these APIs. But really the broad goal is for us to lower the burden for the providers and their staff when it comes to getting prior authorizations, and to decrease the time to get these authorizations so that patient care can be delivered in a timely fashion. And the goal is really to have these APIs set up by January of 2027, so just a little more than a year from now. And so this is kind of a crosswalk of the API terms used by CMS and which of the implementation guides. There are a number of them beyond the 3 burden reduction guides that are listed, but which ones support the CMS APIs. And I thought I had one more slide. Oh, there is one other regulation I wanted to mention, which was the HTI-4, which was put out by the Office of the National Coordinator and the Assistant Secretary for Technology, ASTP, and that just puts into the health IT certification criteria for the vendors that they need to be supporting the 3 APIs that I described earlier: coverage requirements discovery, documentation templates and rules, and the prior authorization support. And this also then brings in the providers so that they have these technologies available to them at delivering care. So now we have vendors involved, providers involved, and payers involved, and hopefully the goal will be to lessen the burden for everyone. So I just wanted to briefly, my last slide, note that there were 2 kind of significant events that happened over the summer. One was this prior authorization pledge. A number of the large payers in the US committed to working to fix the prior authorization. Some of them do provide care through Medicare Advantage, but a number of them are provide commercial care as well. And so the goal is that we move these requirements that we have for federally funded care and get the prior authorization, electronic prior authorization approach adopted in commercial care. So then everyone can benefit from that. And then also during the summer, about a month later in July, at the end of July, a number of large organizations came to the White House and committed to improving the health ecosystem by using standards to improve patient care, particularly in diabetes care and in prior authorization that we've already talked about. So I'll hand it back to Dan. Hopefully, those of you who have heard me before, this only reinforces understanding of these rules. And for those who haven't, it'll help you kind of start off in understanding them. So back to you, Dan.
Great. Well, thanks, Viet, for that overview and for really sort of illustrating how these different components and the interaction between providers and payers is really sort of moving forward. We'll go now to Allison. You have been, Cognizant's been involved in the Vinci Project for a while and has really been working to help support implementation of these sort of policy objectives in CMS as 0057 rule. Could you tell us a little bit about how that's been going and what you're seeing from your side?
Yeah, thanks, Dan. So I think Cognizant is very uniquely positioned as a health tech vendor in the industry today. People may know the name of TriZetto, maybe not as much of Cognizant, but TriZetto does cover on our core claim adjudication systems. We cover 2/3 of the insured population today on our claim adjudication systems. We are also the 3rd largest clearinghouse in the industry under TriZetto Provider Solutions. We have applications in care management, utilization management, quality and risk adjustment management. And we also have a solution that was a part of the interoperability phase 1 under the 9115 rule, where we have 6 of the largest Medicaid plans on our compliance-based solution. So Cognizant, we feel, is very uniquely positioned, knowing that we play on both the payer and the provider side. And we're really excited about this idea of interoperability, or the big I call it, the big I of interoperability, and how payers and providers can be connected. So Cognizant has been involved in Da Vinci for a long time, being noted as some of the creators of the Da Vinci implementation guide. So, I think what's exciting about our participation there is, because of our unique position and the amount of clients that we support and our involvement with Da Vinci, is we really know these guides inside and out. That gives us a really great opportunity to not just implement them, but also find areas for improvement. Where we feel there is maybe not as much representation from the health plan or the payer side, we have an opportunity to pull that in and say, hey, this field is really important to claim adjudication. And I think, last week or a couple weeks ago at WEDI, Danny from MCG talked about this. We don't want to speed up prior authorization and make this more efficient, but then break the claim adjudication process down the road. And I thought that was a really great statement to make, and why contextual information is super important when we talk about the implementation of these APIs. So as far as, just diving a little bit deeper into our participation with Trebuchet, or with Da Vinci, we also participate in the Trebuchet testing activities, which we find very valuable to connect with our partners, or my favorite word is co-opetition, those that we're cooperating with, but we're also in competition with, is really just being highlighted as we start to bring all of these clients and different constituents together, is that really there is a lot of co-opetition happening in the interoperability space. And we're excited about it, honestly. We're excited about expanding our partnerships with our current partners. We're also excited about expanding partnership opportunities with those that we haven't had an opportunity to partner with before. And Trebuchet is a fantastic opportunity to do that. It is really purely based on testing connectivity, testing the workflows, validating the implementation guides. And so Cognizant's participation in that has not only helped us make sure that our products are meeting the requirements, that they are actually producing the value that we're seeking to provide in these implementation guides. But it also is helping us understand, where are these other applications at? Where are these other vendors at? How do we integrate with them? I think standards is a great way forward, and super excited about what HL7 and Vinci is doing. But it's like any other language, right? Sometimes you say hi, sometimes I say hello. And so it's really important that there is collaboration between these different vendors to make sure that we're all speaking the same language and really able to connect and create this interoperable ecosystem. One thing that I did want to mention is Edmund, I did see your question in the chat about the extent of adoption between private payers. And so want to take a second to just address that, because in some of our implementations that we have actively going on, we do see the expansion of non-government lines of businesses or non-mandated lines of businesses coming into the conversation. And I think a big part of that is about adoption. When we tell providers, hey, we have this cool new fun technology that's going to get you information in real time, and it's going to help coordinate care, and it's going to help treat your patients faster, they want to know that that's going to be available for all of their patients, not that they have one workflow for Medicare or Medicaid, and then they have to go back over to the portal or to the fax machine for their commercial patients. So we do see some health plans taking more of a phased approach just to make sure they are compliant. But we do see that many of them are really excited about expanding this, or even starting their implementation with all of their lines of businesses. So we do definitely see the adoption of that. And I think, just the last thing just about the implementation that I briefly mentioned, and kind of the phased approach that some health plans are taking. If you have not started yet and you are a health plan, please get started. This is a huge undertaking. We see a lot of health plans that we are talking to, and I'll start with prior authorization and I'll worry about payer to payer in 6 months. Please get started. These are huge changes. There are lots of vendors out there that are talented and that know how to implement these, but it is no small feat. Implementing these, getting everybody connected, not just being compliant, but also seeing the business value of these, which I'll talk a little bit more in some further questions. It's a huge undertaking. So, happy to answer questions, happy to be of support if your health plan is looking for that, but please get started. It's a lot to take on.
Yeah, for sure. Thanks so much for that, Allison. I really appreciate how you highlighted those different pieces. And, just to kind of build on what you were just referring to, how do I get started? What's available, sort of, if we're just, in a few steps in or partway through this journey. I'll go now to Diego and say, from HL7's perspective, what are some of the things that we've been trying to do to help implementers sort of get prepared in terms of education, tooling, testing events, et cetera. Could you walk us through some of the things that are available to support this prior auth situation?
Thank you, Dan. Let me share my screen and show some live options. So the first step, can you now see my screen or not yet?
Yes, it's painting.
There we go. Yep.
Okay, so this is the Foundry, and you can find it at https://foundry.hl7.org. And it's a place where you can play or try any of our reference implementations. And then when he showed you the diagram of our work, one of the key points after creating a spec was creating a reference implementation. And what's the use of a reference implementation? is to show any stakeholder. One of the uses is show any stakeholders how this works, how it's supposed to work. So Viet mentioned 3 implementation guides. CRD, where you find out whether the patient requires prior authorization for a specific study or procedure. DTR, where you get to know what forms to fill, what questionnaires to fill, and with what requirements and any other documentation you need to review or fill. And finally, prior authorization support, which is the actual authorization given that you have completed all the requirements. And how does this work? We can try it here. So I will look for CRD in the Foundry, and you will see that some of the blocks are for clients and some of the blocks are for servers. And when you have a client, usually you will be able to try the client. So how this CRD works, you can enter there and press the Try It Now button. Before doing that, you can go to the source code here for this implementation. You can leave feedback for the creators. You can ask for support. You can go to the implementation guide, the actual implementation guide, and see what it's like. Go to the Confluence page for the project. And you can see here the licensing options for the reference implementation. Usually we have everything Apache, so open source. You can see here some snapshots. And then if you press Try It Now, I'm not sure if you are looking at my CRD request generator yet. It's loading.
Loading.
It's still loading. Now we have to select a patient. This is kind of a EHR. We are representing what the EHR user will do, in this case, the clinician. So I will select this Bobby Tables patient, and I will request a device, a hospital bed. So once I have selected the patient, this reference implementation will send this data about the patient, the device we are requesting, the practitioner, and the coverage to a system that will decide whether this device requires prior authorization or not. So we will use CDS hooks to ask for this information, and the answer was yes, some documentation is required. And we can complete the form or review the form. So we can go to order form and actually complete in a secure way. We are asking, not very secure here because it's a playground. So the user and the password is user. Don't use this at home. And we can actually fill the questionnaire. So instead of having the patient going to the authorization page of the payer or the clinician team doing this 2 days after, we can do it right now. So if this requires prior authorization and the prior authorization requires some documentation, you can fill the questionnaire now. Not only that, this technology allows to extract whatever information is available in the EHR and fill it for the clinician. So maybe the clinician or the clinician team will only need to fill very specific fields that are the things that are not in the EHR yet. And this can be, you can describe your requirements in a computable way using this kind of technologies. And finally, you can, after send all the documents to the payer, proceed to prior authorization, which will right now trigger the asking for prior authorization to the payer and get the response back. The response may not be authorized or non-authorized. It may be, we have to review this. So in that precise moment, we can create a listener to see when the authorization is processed. They may ask for more information, but most of the prior authorization requests may be solved in this way. So we have a reference implementation for CRD, for DTR, and for PAS. And we also have a bundle. This is called the Burden Reduction Solution Bundle. And what is this for? The same thing I did in our environment, you can do it on your own computer or in your developer's own computer. So you can download everything from here. There are videos explaining, there are IGs, there are some pages for implementer support. These are the prerequisites for running this locally. Usually this will be done by a developer. And the developer can also test the same ID, but in their own environment. It can be just Amazon or whatever environment they want to use. And you can configure the solution. And that will mean that you can also replace one of the components with your own components or feed whatever information you want to feed. This is for not only trying this in the Try It Now page, but also for trying with your own software, combining it with your own software, once you understand how it works. This is in the Foundry aspect. The other thing I wanted to show is the Da Vinci education component. We created 3 courses, one about the FHIR core standards and technology, 28 hours of videos and materials, introduction to FHIR, how to read an implementation guide, what is US Core, Smart on FHIR and CDS hooks, what is CQL and how it works, questionnaires and SDC, FHIR security, FHIR resources for implementers and bulk FHIR. And then specifically for burden reduction prior authorization, the introduction to Da Vinci, and all the implementation guides, healthcare record exchange, member attribution, CRD, DTR, and PASS, CDX, and CQL for CRD, and questionnaire and SDC for DTR. And the people that created this is the same people that created the implementation guides. So you cannot get better education than this. And finally, the third part is PDEX, and it's only 7 hours, videos and materials. Materials can be demos instead of just the video with education. So all of this is available from our education site. And that was my contribution.
Terrific. Thanks so much, Diego. That was really awesome. And I think it's really important to underscore how, this open source software is really meant to sort of facilitate learning and experimentation and pairing with the development of your solution. If you're doing one part of that piece, it gives you a sort of a counterpart to test early, even before you start connecting with your sort of pilot partners. You can sort of have that rapid interaction that's really tremendous, as well as, Allison sort of made the call to get started now if you haven't already. Certainly there's a wealth of educational resources that are available. Vet, you mentioned in the overview around sort of the regulatory context and sort of the rules like HTI4 that are sort of on the provider side. There are other interoperability rules that sort of are applying on healthcare delivery organizations and their use of FHIR. And the CMS rule has not only prior auth, but some other APIs defined as well. And I'm wondering, for the panel, if you could sort of zoom out just a little bit and sort of think about the core components of the technology that you all have described as being important to facilitating this really complex workflow are actually sort of foundational and could potentially be used for other things too. And while it's really important for this use case, it's a huge problem. It's a major initiative, and there's sort of regulatory implications. I don't want to sort of have us only zero in on that. It's only for this sort of compliance aspect. There's other potential uses for this kind of an investment as well. And I wonder if you might comment on how you see that these components and these technologies potentially applying in other contexts as well.
Yeah, it may not seem obvious as we're describing it, but there are many building blocks to a FHIR. Dan, you mentioned a number of different technologies that can be put together in what we call an implementation guide. Each of those processes, the DTR and PAS, are really manifestations of implementation guides where we explain to the developer, this is what we expect the workflow to be, this is what we expect the data elements to be, what's being exchanged. And that workflow really comes from the community telling us how it works in the real world today. And so we want to match that. But we can reuse these tools like the questionnaire. We have an example of how we do it in prior auth, but questionnaires are really great for other purposes. If you're wanting to collect coded data for public health, for surveys of patients, there's any number of ways that you can reuse the same FHIR technology for another purpose in another domain. I'm very excited that the CDS hooks capability is now in HTI4, and that CDS hooks allows the EHR implementer particular areas in the workflow, like starting a new encounter or ordering a procedure like I showed, to then utilize clinical decision support. So we may use it for prior auth, but in the future, we hope to be using it to just improve patient care by helping the clinician with best practices. There's any number of those examples, and what I want to reassure folks is, repeating what Allison said, get started if you haven't gotten started. But once you have gotten started, you're building upon things you've already can do. So the payers who've already implemented the patient access API rule, the 9115 that Allison mentioned, they've already gotten started in FHIR. So this is just an iterative improvement in the capabilities that they're going to be offering. So we're, of course, we're technologists and informaticists, and we love interoperability. But I truly believe, after 20 years of doing standards in interoperability, this is really going to be a really great technology as more and more folks start to adopt it. And just in one quick note, Dan and I were both at the American Medical Informatics Association meeting this week, and they put on a FHIR app competition. And we were really excited to see that there were folks using FHIR in nutrition and dietetics. So the ability for us to extend the capabilities and the data that's in the EHR to help serve the specific purposes of specialists and others who provide care is really exciting.
Awesome. Alvin, do you have anything you want to add to that?
Yeah, I was just nodding along because I totally agree with everything you said. Yeah, I do think there's some really beneficial aspects of the foundation that is being laid today. And I think that that's also a really important thing for implementers to take into consideration, that this has the ability to really go beyond the mandate. I think it's really important that as people are looking at vendors, as people are looking at solutions, that they go beyond just looking at how am I going to check the box, that they really start to dig into the business value that these data exchanges are going to bring to the health plan, to the providers, to us as patients, right? We're all patients as well. And so I think that's what gets me so jazzed is that, it's something that's going to benefit us all individually as well, your grandma, your dad, your mom, if you think about, who this is going to impact. And so, a couple of things that I just wanted to mention that are additional benefits is one, just setting the expectation for transparency. I think we've been living in a world where that hasn't been as much of an expectation as we would like to see. And so I do think that these CMS rules, I think these APIs are really setting a foundation for the expectation of transparency between payers and providers, and it's just going to grow into that. So one of the notes that I had on this question was the natural extension into the use of this information into other use cases. So be it mentioned clinical data exchange, that's a very natural extension of prior authorization. It also extends into the claims process. If the claim is pending, how do I request information? So making sure that as implementers are going through this, that they're not just thinking about kind of this little box of prior authorization, but the natural extension of those things like care gaps, right? This information that you gather via the DTR process, information that's going to be made available, clinical quality language, or just via CDS hooks in general, can be used to help close care gaps. And there's an implementation guide out there. Risk adjustment, social determinants of health. Dan mentioned the Gravity project. So that's also a very exciting project that Cognizant is a part of. And we have the ability to get involved and help drive the intersection of these different types of workflows and the data that's used. So I think it's really exciting to see the opportunity of the intersection of this data to be used in other use cases. And so as you get started, just remember that it's important to look beyond just these prior authorization workflows or just checking the box, because what you invest in and how you set yourself up for the rest of data exchange is going to be really key and important going forward.
Yeah, that's terrific. Thanks. Thanks so much for those comments. I wonder, not everyone is at the same part of this journey. Some are, just sort of digging in now. Others have been, at this and at the table for quite a while, sort of helping build the standards and test them out and so forth. And I wonder, if any of you have thoughts on some of the early lessons that folks have learned as they've begun to do this, any key things to sort of watch out for, or important sort of take-home lessons that those who are with us today, might sort of jot down and dig into. And I'll before I pass it to the panelists to answer, I'll also say, for those of you who are listening in, feel free to put your comments or questions in the chat as we go, as we wind down here. We have some space to answer questions that you might have as well. But anyway, thoughts on some of the sort of key lessons that folks have already learned as they've begun this work?
Yeah, I'll start out. A non-technology lesson learned, which is something we say often in Da Vinci and often in HL7, is that interoperability is a team sport. So the getting your entire organization understanding the importance of interoperability as a corporate value, if not a corporate value, kind of a mandate, in the same way we think privacy and security are so important. Having the support at the executive level all the way down to the developer who writes the code is really important, because then the executives can understand how FHIR can be used strategically, and the data used to educate AI models or other ways of improving care or delivering care or making it less expensive, hopefully in time. If we think of interoperability just as these technical requirements, you really lose out on the strategic opportunities when it comes to interoperability in FHIR.
I'll go ahead and jump in here and just, obviously second that. But yeah, I think a big one is also looking at the fact of use case
Oops, I think we might have lost Allison there for a moment. We'll see. Hopefully, her internet
Yeah, I
connection
want to comment on
comes back
something
on. Yeah, go ahead.
while we wait.
For sure, Diego, go for it.
I think that the very important thing to understand is this is not just interoperability per se, it's a change in the workflow. And the change is in the provider workflow and in the payer workflow. So when they say start working on it, it's not because it's a technical problem. It is a technical problem, but it's not just a technical problem. You need to make sure that the teams that will be providing healthcare will deal with this in the new form. Like they really will, instead of having to do what they do now, which is fill in the blanks later, they will really do it almost online.
Yeah, I think that.
And on the other side, from the payer perspective, they will have to, whatever they are doing now in a separate portal with its own web format and definitions and workflow, they will need to integrate that into the provider workflow. So all the rules that they are now in some buried somewhere in the payer, now they need to be active. They will have to respond to the provider request. So that's my 2 cents of confusion.
I've heard some concerns that you're adding more work to the provider workflow, but I disagree. I mean, having the provider there with the patient, doing shared decision making, I think it has a lot of value. And I think we often forget, and sometimes the providers forget, they're getting interrupted in what we'll call their pajama time, the time that they're not seeing patients, but they're doing administrative tasks. And if they have to go back and fill out forms, then they have to hop back on the computer, remember what was the encounter, what they ordered, and it just delays care. So we want to try to decrease the disruption in that pajama time and give back the clinicians that free time.
Yeah, and my second comment was about technology itself, and just to highlight what you said about these technologies will be used elsewhere. And that's what is happening. We are getting more and more use of the FHIR family of technologies like CQL, CDS Hook, Smart on FHIR. They are in regulation, but not only for this. They are beginning to be in regulation worldwide for all the clinical and financial workflows. It's not just burden reduction.
Yeah, we see other agencies other than CMS starting to write rules. FDA has been sending out RFIs regarding the use of standards, FHIR standards, I'll say, because there are already existing standards FDA uses, but public health. So there are lots of opportunities for reuse of the technologies and the knowledge that we gain in implementing FHIR.
Yeah, I know both of you know, but one of the other hats I have at HL7 is as Chief AI Officer, and certainly one of the conversation points, well, everywhere I suppose, is about AI and the use of AI in healthcare. But in particular, I'm thinking about the ways in which AI decision support can be integrated into clinical systems, and CDS hooks is one of those fabulous sort of techniques where the place within the workflow that a decision needs to be made can be integrated with an external application system through that same technology that we're using here in this burden reduction use case, but perhaps to connect to a decision aid powered by AI in some context, and pass that context back and forth. I'm curious if you all have other comments about how artificial intelligence may be a enabler in this prior authorization context as well. And Allison, welcome back. Glad to have you.
Thank you. Sorry about that.
No problem.
So I think with regard to your question, I think we can all agree that when you want to train AI on good quality data, not just volumes of data. And I think initially, as we're using very deterministic, we'll call it, requirements for prior auth and getting coded data back to the payer, that's another strategic opportunity. Are they using that coded data not only to answer a single prior auth, but improving prior auth at questions and data content to get us to learn AI and figure out maybe we can avoid having to do prior auth altogether if we know that we can, in a good relationship with a provider, see the patient's data and say, oh yeah, that makes perfect sense. This provider has been delivering standard of care. We just authorize the care, so that in time hopefully will improve on being able to do that from the payer side based on good quality data.
Allison, do you have any thoughts?
Yeah, I'm assuming that you guys talked about the AI opportunities kind of in the standards, and I took a little bit of a different approach, and I know there's some folks out there. So I do think that AI in the world is so much bigger than just getting authorizations into the system, right? These health plans have huge applications and workflows and processes for determining, utilization management, right? We have medical director workflows, we have guideline identification. So I really see a lot of value in the utilization management space. Beyond just what you guys covered about, the integration pieces of it, but I think in the actual world, because authorizations exist for a reason, and I do think it's important to make them efficient in how we're managing them. So routing and queuing, like I said, guideline identification. I do also think from an implementer's perspective, we're using AI in our development, in our testing suite. So just to reiterate again, this is a beast. This is huge. So just the ability to include AI in development and testing, because we do want to be careful in its use of authorizations. There's a lot of states that are kind of setting the trend for legislation against AI and automation in the world. So I think it's important to also focus on the opportunity in process improvements, development, testing, queuing, guideline identification. So I'm really excited about AI in those areas.
Terrific. So we are winding down here. We're actually close to the top of the hour. I think maybe we can close out just to kind of come back to maybe some practical next steps that folks could take. And so I'm curious if you could mention any events, opportunities, activities, things. How can folks get involved in taking their next steps on this journey?
I'll jump in first. As Dan showed earlier in the hour, this is a virtuous cycle of standards development, implementation, testing. So so these guides that we talked about are continuously being improved. So if you want to be part of giving input into that improvement and engaging in standards development, at least for the Da Vinci one, you can go to confluence.hl7.org. You'll find all of our work groups, our Da Vinci, the guides. We are firm believers in community. So the more the community can contribute to the work of the standards, the better the quality of the standards will be. So we want to encourage you to get engaged in either in Da Vinci or the burden reduction or in our other accelerators or our many other projects within the HL7 community.
Awesome. Yeah, I'll just add to that. I think Drummond is a great testing resource. They're doing a lot of managed testing. So look into Drummond. We also have, the HL7 Connect-a-thon coming up, which is really exciting in Q1 of 2026. And they host that, multiple times a year. And I think just Trebuchet, like Trebuchet is out there. It's been out there for a while. I think its participation is lingering a little bit, but I think they're a great opportunity to engage in some testing activities as well.
Fantastic. And of course, as we close this down, we want to draw your attention to Vive coming up as an event here, in which all of us will be gathered and lots of conversation happening around this space. And all of you who attended today can use a special code to receive a discount on your registration to Vive. That code is shown here on the screen. I think a link will be coming up in the comments section as well. But just to close out, I want to thank you all for your attendance today. I hope you learned something, got some action items, and are excited about what this kind of interoperability work can do for you for prior authorization and hopefully for other opportunities as well. Thanks so much, and hope you have a great rest of your day.
Thank you, everyone.
Bye.
Thanks all.